Hello, and how are you? Welcome to a beautiful session on bronchiectasis, where we're going to focus on pathophysiology and management. My name is Winnie Barrow. Kindly don't forget to subscribe if you're new, and if you don't know what we do, this channel focuses on lectures, lessons, and expert interviews pertaining to healthcare. Keep it with me all the way to the end. By definition, bronchiectasis is a chronic dilatation of the bronchus and the bronchioles due to inflammation and destruction of the walls. This is a chronic respiratory condition, and the main effect is whereby it leads to bronchial wall dilatation, what you can simply say widening, and thickening due to inflammation and extreme presence of infections. So what does it look like when bronchiectasis occurs? Bronchiectasis, being an inflammation disease, basically means there's inflammation of the walls, and these walls we are referring to are the bronchi and the bronchioles. And with the inflammation of these walls, there is increase in secretions, leading to extreme mucus being accumulated in the airways. But again, something is happening in these walls. Apart from being inflamed, the walls are also being destroyed. So we talk about dilatation because there's destruction of these walls. So here's a good example that you can see. We have the goblet cells that are releasing for us mucus, and they're releasing a lot of mucus. So we are saying increased secretions. But the walls are also being destroyed by these infections, and because of the wall destruction, the dilatation happens. So we have a widened, dilated walls or widened walls, not because of inflammation, but because of the destruction of these walls. So the infection that is happening here is causing a widened airways. So unlike other diseases like pneumonia, where we have constricted airways and we have, yes, overproduction of mucus, but the airway is so small. In bronchiectasis, the airways are widened or they are enlarged. So in this case, you end up with a very wide opening, but it's unfortunate that this dilated airway is also destroyed and it has excess mucus. So on the causes of bronchiectasis, the cause can be widespread all the way from congenital causes to allergic causes. So we have the congenital cause, which can include cystic fibrosis. Then we have causes such as pulmonary infections that can exhibit the presence of this inflammation and further destruction of the walls. Then we have obstruction of the bronchi by obstructive substances like tumors, foreign bodies, thick vomiters, or even aspiration materials. So in the presence of an obstruction, there is a trigger to start inflammation processes that can actually lead to swelling and destruction of these walls. But we also have cases of immune deficiency from conditions like HIV and AIDS. There's activities of autoimmune disorders, including systemic arthritis, sorry, not systemic, but rheumatoid arthritis, and then you can have cases of lupus erythematosus diseases. So this autoimmune, meaning you can have a case where they are destroying these bronchial walls and causing them to widen or making them to become very weak and widen up. So the cause of this destruction can be from such illnesses. And then the other case, you can have an occurrence of what we call allergic bronchopulmonary aspergillosis, a condition that is an allergic reaction, and this reaction can stimulate an inflammatory reaction, and the inflammation can actually happen in our bronchial walls, causing the distractions, causing the oversecretions, and bringing out the aspect of inflammation in these areas. So here's an emphasis so that you can understand that in bronchiectasis, as much as we have excess mucus production, there is wall destruction, there is loss of the cilias, there is extreme mucus production, and the walls end up being blocked, or the diameter and the airway ends up getting blocked with this thick mucus or thick gelatinous mucus. So here's our normal airway, very clear, easy entry and exit of airway. There's proper and clear breathing patterns and breathing sounds. However, when this gets affected, then this what can end up as. So, what's the pathophysiology of bronchiectasis? So, the pathophysiology apparates more of like a vicious cycle, and I would like to start here. I hope it's clear and can be seen. So, the first beginning part is the initial infection or the initial causative agency that occurs in the system, and the presence of this initial infection or infective agent causes an inflammation, and it releases all these inflammatory triggering substances like cytokines, the neutrophil enzymes, and bacterial products that can exhibit the inflammatory reactions. But now, when inflammation occurs, there is swelling, there is overproduction of mucus, and tends to affect the mucociliary clearance, or rather, it affects the ability of the airways to clear the mucus. And with this excess mucus secreted, then you can have hypersecretions and obstruction of the airways, mainly because of the thick mucus plug that has been produced and exists in the airways. So the hypersecretions and obstruction further leads to more microorganism colonization and infection. Well, this microorganism can include viruses like Haemophilus influenzas, Pseudomonas aeruginosa, Staphylococcus aureus. All these can be possible causes of our disease. So the microbial colonization and infection fill up this space and it worsens this inflammation. But now the extreme presence of these infections can cause now further bronchial dilatation because of the airway destruction or because of the air wall destruction. So if you don't manage it, the cycle keeps on. So the inflammation comes out again. We impair the clearance. The air mucus comes too much and blocks. And the microorganism colonization and infections keep on existing. And so we get to have extreme disruption until now the airways are not able to function further or we end up with some insufficiencies. So that's a summarized way to look at it. But here is a more clearer picture that looks at the triggers. And the triggers here, we're talking about the causative agencies, possibly the diseases that we mentioned below, before, sorry, like the HIV and AIDS, immunocompromised status, causing now the inflammatory reaction. And in the presence of the inflammation, then we have ineffective pulmonary defenses or ineffective pulmonary reactions that causes excess mucus production or excess hypersecretion of the fluids, and we impair our mucociliary clearances. With extreme elongation of this impaired clearance, we end up with lung damage. And with the lung damages, it keeps on cycling these triggers. And so you may end up now with total damage of these airways and the pulmonary functions ends up impaired or end up failed. And in this case, you can talk about lung failures or respiratory failures. So, in clinical manifestation of bronchiectasis, we can have aspects of persistent cough, which comes with production of copious amount of purulent sputum. There's intermittent hemoptysis. Hemoptysis is the presence of blood during cough or when someone coughs and they produce sputum, you will see traces of blood in that sputum. There's also aspect of breathlessness or difficulty in breathing, and the client can also present with fever, that is high temperatures, accompanied by bouts or recurrent states of pulmonary infections. Then we have aspects of crackles and rhonchies when you do lung auscultation over the lobes that have been affected. And in extreme cases, our client can present with finger clubbing. So presence of finger clubbing shows extreme impaired gaseous exchange or extreme impaired tissue perfusion, and in this case you need to initiate supplemental oxygen administration to just help with regaining the oxygen levels in the blood. So in this case here is summarized symptoms: short of breath or difficulty in breathing, chronic productive cough, the recurrent chest infection, and instances of weight loss. So diagnosis of bronchiectasis can check with chest X-ray, which will reveal areas of dilated bronchus, because remember we said with bronchiectasis, this disease is more into dilating the bronchioles, and in this case, the chest X-ray might reveal that. Then you can go for sputum examination to detect the specific microorganism that has invaded the area. These cases of high resolution CT scan or computed tomography scan, which is useful if you really want to identify the dilated areas of the bronchioles. Then there's culture sensitivity, that is to determine the microorganism that is causing the disease. There's tests like lung functioning tests, specifically spirometry, that can enable us tell the efficiency of the bronchioles when it comes to airway entry and exit. And we can also perform bronchoscopy to just again visualize the dilated areas of the bronchioles. So management of bronchiectasis, it's widespread. However, in this case, you may not really have to deal with like the causing disease, but you can focus more on the key manifesting needs of the client. For example, it's important that you look at infection control and management. And in these cases, you can stop risky behaviors like smoking. So there's need to stop smoking or to cease smoking, and control other respiratory irritants that can influence further inflammation of the airways. Remember, smoking components has an effect of irritating the bronchioles of the airways, and they can exacerbate the irritation process. Then prompt antimicrobial treatment, that is, for example, macrolides, to just clear the infection and to prevent further inflammation processes from occurring. There's also importance to immunize our patients or to take immunization against pulmonary or potential pulmonary infections like influenzas and pneumococcal vaccines. This will help us free from contacting any form of respiratory infections that can trigger inflammation and cause damage or cause inflammation cases that can end up into bronchiectasis. And the other management includes promotion of secretion clearance, e.g. participating in physiotherapy, administration of fluids, ensuring that the client has proper positioning to consolidate the fluids and remove them, such as semi-Fowler's position. We can talk about sanctioning, all that can help us remove the excess fluids. And then the other bit is hydration. And in hydration enables us to increase fluid intakes, to just reduce the viscosity of the sputum and to promote expectoration, whereby during the coughing exercises, the client can basically remove these excretions or remove these secretions, and they can be eliminated. And the other bits could be administration of bronchodilators. Remember, as much as our bronchitis disease leads to dilation of the airways due to the distraction, remember this is an inflammatory reaction. So there will be some state of bronchospasms, and to help with this, it's advised that you have some bronchodilators administered. The other bit is broncholytics, that is drugs to help us thin the mucus so that it can easily be removed. And in extreme cases, you can go for surgical resection, where you can do segmental resection in case the other management fail. And this is more effective if you're dealing with tumors or cancers of the lungs that are possibly obstructing the airways and making the patient not able to initiate breathing. So you can go for resection procedures. Oxygen therapy is helping us with promotion of breathing and supplementing of the air because of the blockage or because of the extreme inflammation and blockage of this airways or air openings. Remember, there's excess mucus produced, and this mucus is blocking this airway or is limiting the airway entry. And for this test, you will need to supplement oxygen to help us with promoting of the tissue perfusion. Otherwise, you can have organ failures or organ issues due to poor metabolism and poor management of the system functions. There's environmental control, that is maintaining clean spaces, avoiding pollutions, and ensuring that there's no presence of environmental irritants that the client can be exposed to. And the other bit is avoidance of foods that contain allergens. And foods that contain allergens could be examples spicy foods or foods that are over prepared with too much stimulating products or substances that can actually affect the patient. You can talk about complications, which can include atelectasis, fibrosis. Fibrosis means thickening of that wall due to destruction of the connective tissues, and they end up either thickening or scarring. And the other bit is respiratory insufficiency or failure. This comes along where there is severe destruction of the bronchial walls and there is failure now to establish proper entry and exit of airway of air. And in this case, you can have now respiratory inadequacy or respiratory failure. And the other bit is antibiotic resistance. When there is prolonged administration of antibiotics, the immunity of the client may become resistant to these drugs. And in such a case, we talk about antibiotic resistance or drug resistance, whereby even if you administer this medication, they may not have any effect or they may not present with any response to the client in terms of clearing symptoms or improving the disease progress. So thank you for staying with me to the end and listening in all the way to this last bit. So if you enjoyed, please comment, share, subscribe, and also give it a thumbs up. And for those who keep coming back, thank you very much and see you in our next lessons. Bye.